Hi, we can go live now. Thank you for your patience.
Sounds good, no worries. We're good, by the way.
Okay, good morning, everyone. My name is Tina Shah. I'm a senior analyst and portfolio strategist at the Kansas Health Institute, and you are here at the Quality of Care and Protective Services Working Group convened by the Senior Care Task Force. This is meeting number 10, and so we're continuing to refine and characterize your recommendations today. I hope you had a chance to review your recommendations so we can get going on this. I'm going to share the agenda briefly. And so I want to make sure you keep your meeting commitments really top of mind as we discuss all of your recommendations today. So come ready to discuss and compromise. Keep your remarks succinct and on topic. Don't hesitate to ask clarifying questions, and I'll make sure we start and end on time or ask you for grace if we need a couple more minutes. Your vision statement, just to bring everyone to this meeting, is older Kansans will have access and the ability to choose and receive high quality, person-centered services wherever they reside. So I do want to make sure everyone is very present for this meeting. So in our normal fashion, I will popcorn around and ask you to introduce yourself and really talk about what you want top of mind as the working group is going through refining these recommendations and characterizing them. And so I'm just going to go around my window. So I see Jan first.
Ah.
Oh, sorry. I can go to someone else if you want.
No, that's okay.
Okay.
Jan Kimbrell, Kansas Silver-haired legislator representing Morris County. Yes, I would like to keep in mind that services for the seniors are at a critical stage and only going to get more so with the expanding number of seniors that enter into this populated age group. And that location of where they are living should not have such an impact. And we need to be more equitable with that. So thank you.
Thank you. Next, I see Camille.
Good morning, Camille Russell, State Long-Term Care Ombudsman. And as always, I want to make sure that our decisions we make are really looking to be person-centered and impact the quality of life of the individual. So thank you.
Thank you. Next, I see Ernie.
Thank you, and good morning, everyone. So thinking about rebalancing, mental health services and protections from abuse and neglect must be coordinated across all appropriate health, long-term care services, aging networks, community settings, to ensure that people have a choice to how they live safely as they age. Thank you.
Thank you. I see Rachel next.
Good morning, everyone. Rachel Perner, an attorney in private practice and elder law. I want to see coordinated efforts across different domains in order to avoid exploitation and abuse of our elders.
Thank you. Next, I see Lee. Lee, are you on? We'll come back to her. How about Chrissy?
Are you there? Are you
there? Yep, I hear you.
Yep, I hear you. Sorry. Hello, everybody. I'm having to phone so I can see you, but you can't see me. I'm Lee Chaffee. I work at Brewster, and I'm representing adult care homes. And I would echo what Camille says for all seniors in Kansas, just that the seniors have the right to choose the kind of care, and that Kansas is the front runner in providing all different kinds of resources for care for our seniors. And that if a senior does live in an adult care home, that they still have rights to choose what kind of care they get, because the adult care home really is their home, it's their address, it's where they get mail, and they should have the right to choose great quality care that Kansas provides.
Thank you. Chrissy?
Good morning, Krista Katib, Deputy Director for Adult Protective Services, State of Kansas. I'm very interested in any sort of prevention program for abuse of elders. We know that older adults are often embarrassed or ashamed to come forward when then they have been a victim. And so how do we work through that stigma and then provide them with the supports that they need so they can choose where they want to live?
Thank you, Chrissy. I've got Tracy next. Tracy Davies, are you on? All right. Well, we'll let her introduce herself later once she is back. I also want to announce that we have Leanne Thone from KLRD on as a resource if we need her, and Emma Urich on as well, who is my colleague. So with that, I'm just going to have us dive in unless anyone has any questions up front. All right, and a note that the exercise we're going to do today, if we don't finish it, we will send out a survey. We'll also send out a survey just because there are some missing work group members. And so they'll have a chance to kind of weigh in as well. So you'll have kind of two opportunities. All right, so in your email box, you should have received kind of a list of the recommendations. The only cross-cutting recommendation that I couldn't really find a place for, but you are welcome to suggest a topic for it, is reinstating that Governor's Conference on Aging. And I wanted to make sure you wanted to call it the Governor's Conference on Aging, so we will get to that. Then you have about 4 recommendations for your first topic on administration of antipsychotics. For your topic on safeguards to prevent abuse, neglect, and exploitation, you've got about 10 recommendations, and I am looking to see how we can maybe consolidate some and combine if we can, and we'll do that through the matrix. And then for adult care home surveys and fines, there's about 8 recommendations there, 8 to 9. So we'll definitely continue to try to consolidate as we can. But at the same time, consolidating doesn't have to be done as well. Just remember that in the final exercise, we will be tiering these recommendations. So you'll be ranking kind of what should be done first. And so if you have more recommendations, maybe you'll, have a smaller set up front, a little more in the middle, and a little more at the end. We'll think about downstream and upstream effects and everything. So don't feel like you're being forced to compile a recommendation. Know that if it's actionable as an individual recommendation, then combining to have a super recommendation. Any questions on that? All right. So then that first one that's about, the statewide conference or reinstate governor's conference on aging. Are you comfortable with the language? Any edits there? Let's start there first. All right, the language looks good then. The rest of it you had pretty much filled out. You had talked about action leads as associations and such, and KDADs in the executive branch as well. I know that data isn't here, but you had talked about it before. Did anyone have anything that they wanted to really bring up about this recommendation before we move on to the next one?
This is Camille, the State Long-Term Care Ombudsman. Simply that I think that conference actually touches upon most of our other recommendations and really kind of pulls it all together. So I'm glad you actually couldn't find a spot and put it at the top at the moment.
That's where it is for now. So you can decide how you want to tier it after. All right. So then let's move on to your administration of antipsychotics recommendations. So take a look at that language. Require geriatric psychiatric prescribers to be reimbursed, to complete medication checks or provide consultation services for seniors receiving home health services and utilizing telemedicine when applicable. Go ahead, Jan.
Yes, I would like to possibly add after the word applicable at the end and available, because not all. Yeah, thank you.
Any objections to adding that language? All right. Any other suggestions to the language itself? Well, how easy would it be to do this? How easy is it to get a group of psychiatric prescribers to complete medication checks and be reimbursed for that. Is that a change in what's being currently done? Because is it a new reimbursement, or is this kind of making sure that it's being done?
This is Camille, the State Long-Term Care Ombudsman. I do, and Lee may be able to speak to this as well, better even, but there is already reviews done for medications, and so I kind of question, at least in the nursing home setting. So I do question this as an application and be duplicative.
Is it also something done in like home-based services? So if you're living in the community? And go ahead, Lee, with your comment as well.
Hi, this is Lee Chaffee. I would echo what Camille is saying. This is offered in the adult care setting, but I do think we were talking about out in the community.
Right.
Is medication management available? I would wonder, who is that? The MCOs that would be reimbursing? So is that what we're asking for? Is that the MCOs? So that would be anybody covered under Medicaid? Is that what this is about? Because otherwise, if it's a federal reimbursement, I don't think we have much influence on that here at the state level. So we maybe want to make this specific to what the state can reimburse. It doesn't really make specific where that reimbursement's coming from.
So would this be only applicable to those on a waiver then? Is that what I'm hearing, Lee?
That's what I would think. I would open it up to the group who might, I don't know if Bill's on this morning, or those folks who maybe work with those in the community, but yes, that's what I would say. Be a little bit more specific about where that reimbursement's coming from.
Any thoughts? Otherwise, I can reach out to some of the members that are missing today to get some clarification. Okay, it sounds like we won't characterize this, and I will get more clarity before we move forward. Any objections to that? All right. Okay, then our next recommendation is on the state of Kansas shall increase funding for community mental health centers. How about any edits to the language here? Go ahead, Jan.
Yes, my concern is the where it says increase funding for community mental health centers for expansion or reopening. My information is, and my experience is, that many community mental health centers were closed under the previous administration, and many communities do not have them now. And so I don't know where the language fits, but yeah. And if that fits.
Do you want to add that as one of the action steps?
Does that make sense to other people?
Access across the state. Well, is it expanding the actual centers then across the state? Is it increasing the number of centers? Is that what I'm hearing?
This is Chrissy Katib with Adult Protective Services.
Sure.
So I think this is around, if I remember correctly, this is more about having mental health clinicians that have specialty in older adults.
Mm-hmm.
And the one thing that I did feel like was missing from this was that we know a lot of our older adults sometimes don't leave their home, they don't travel, they don't drive, so that these services really need to be in the community with therapists going to the home.
Okay.
So, oh, sorry.
So we have adequate number of reimbursed community mental health workers. So expanding the workforce that way with community mental health workers and therapists. You could consider, I don't remember if there was a telehealth component that was weaved into this one or a later one, but that's another area you can think about. Long-term care to increase access to services, establish a senior care navigator to help with navigation. The consultation services is kind of where there was some discussion around you know, how do prescribers, which are limited in the state, kind of provide services to these CMHCs as well. But happy to add language on expansion across the state or expansion of the workforce across the state to be able to serve those in their own homes or in the community, if that's the wish of the group. Go ahead, Jan.
On number E, to provide consultation services, would it be appropriate to say to provide direct consultation services to the client, whatever that phrase is, to provide direct consultation services for,
Like that?
yeah. And whether that's a telemed type of thing, but or in person. I would prefer in person, but that's not always available. But if they could actually get on Telenet, which some communities can't, and some homes can't, but there needs to be a contact. Yeah. But just put that out there, see what other people think. But
Thoughts? Lee, you have your hand up, so I wanted to make sure that wasn't that you didn't have your hand down or you wanted to say something.
No, I just forgot to put it down, so I will slowly
okay.
put it back down.
I see Ernie's hand go up and then Camille's. Ernie, I think you're on mute.
Ernie Ketzley, ARP Kansas. Sorry about that. So I'm wondering somewhere down through here if we talk about education of unpaid caregivers in community settings. Some of the research we've done shows there's approximately 340,000 unpaid caregivers at any one time in Kansas caring for seniors, loved ones, whatever. So how we reach out to them with information about mental health services, their abuse and neglect would be
So
my
would you want
question.
the CMHC reaching out to those unpaid caregivers to give them education? Is that what I'm hearing?
That could be, or just statewide campaign to reach out to folks.
That might be a separate recommendation because the core of this recommendation is the state of Kansas shall increase funding for CMHCs. But hold that thought if we can fit that in somewhere else or if we haven't addressed that already on the education. And I will say Working Group B has a workforce education component too. Camille, what was your comment?
Well, it does appear that as we are making these comments, it does appear that they're fitting into what is established here, but it may not be that, like, we know what is we know what we said, but it isn't really quite specific enough. Because what Ernie said really may be able to be covered under D. And what we were talking about earlier about in the home, it says on A2B, it says all settings such as, and maybe it just needs to say in the person's home. So anyway, I just am thinking that what our key points were may be able to be highlighted more directly.
Would you want that into just the language of the recommendation? I mean, this is the full recommendation language. These are your bullet points here. But would you want it as one big paragraph instead of just key points? Would that be more helpful? Go ahead, Rachel.
I'm confused about the senior care navigator position. Are we talking about one person for the entire state, or are we talking about establishing?
You're echoing, but it's at every CMHC. This position would be at every CMHC. Does that help respond? Do you want that specificity in there? Okay. Go ahead, Chrissy.
So I would ask the group to consider on A2 Therapist skilled in senior behavioral health care to offer in-home case management. And again, just based on my experience with adult protective services, we see older adults that won't go to a community mental health center, but they would let people come to their home and provide services.
Can you tell me which one this is? This one, B?
It's A2A,
Okay. For in-home
and it's
services.
to offer in-home case management.
Offer in-home. I think we have that already, right here. Are we removing the offering of case management?
This is Camille, the State Long-Term Care Ombudsman. I think our point that we feel like may not be highlighted well enough is the in-home option.
Yeah.
Expansion across the state for in-home services or home-based services.
I think our individuals understand in-home. That's my opinion.
Yeah.
Okay.
Plain language is good.
I would concur with Camille that in-home is very specific, and people understand in-home means literally physically in the involved adult's home.
Does this work then? The state of Kansas shall increase funding for CMHCs for expansion across the state for in-home services. And here are some action steps as well. Yeah? All right. Are we overhauling, changing, piloting? This is a new program. What are your thoughts?
Overhauling.
Okay. Any objections to overhauling? All right. Is cost going to be a barrier to implementation?
Camille Russell, State Long-Term Care Ombudsman. The upfront cost would be extraordinarily less than long-term cost of not doing it.
So there's a cost savings built in. Okay. Does the recommendation include strategies for continuity? Is it sustainable by allowing people to stay in their homes? Okay. What process? How are you going to achieve this recommendation? What's it going to take? Go ahead, Jan.
Yes, would it be that navigator coordinator position that we're asking to be put in at the centers? Would that be their responsibility to do the follow-up?
Definitely.
So
So how does this get executed? Where do you get the money from? Who does this work? Who starts this?
This
you
is
need
Chris Katib, Adult Protective Services. So again, Bill would know the community mental health centers much better than I, but to me, it makes sense that this might be something where legislatively some startup to get staff hired, but there is through health insurance, through Medicaid, have to look through Medicare, but there are ways to reimburse, but they may need startup costs.
Okay. Any regulatory process need to be updated at agencies?
Hi, this is Dr. Tracy Davies, nurse practitioner, and I think the regulatory process has to do somewhat with certain settings. So, for example, nursing home for mental health doesn't allow for separate billing.
This is for in-home services, not to cut you off, Tracy. So would it pertain to in-home services?
Well, I guess it depends on how you define home, because isn't the nursing home their home?
no.
So
Well, that's, I think, the clarity that needs to be made.
Yeah.
And I think the clarity everyone wanted. So if in-home is still being considered a nursing home and not a home in the community, which I'm hearing the working group saying, we need to work on that definition then. Tracy, do you have any other language to offer that would make that more specific? So this is not talking about a nursing facility?
Oh, so that's not? Oh,
No, it's in-home services.
well, I think the general public would probably recognize in-home as not being in a facility of some type.
How about we just put non-facility for now as a placeholder, and I will talk to people about language. All right, so knowing that it's in-home, is there a regulatory process that needs to be updated? I'm thinking about Lee, who said that, you know, what can the state do and have control over? Would KDADS or DCF or anyone need to establish anything? Think about that, if it would or not, but definitely the startup costs. Go ahead, Camille.
This is Camille, State Long-Term Care Ombudsman, and I just have to make the comment that I feel like that this topic was brought to the Senior Care Task Force attention to be addressed about the inappropriate use of antipsychotics in settings. And I feel like we may still have more work to do on this topic to make a good recommendation about that, because what we're looking at may or may not address what our original task was. Totally.
Okay. Then definitely keep thinking about the language. Are there, so will it benefit seniors living in Kansas? Yes, this one's more relevant to those that are living in their own home, correct? And maybe we can add that as in their own home here to give that specificity. Go ahead, Chrissy.
So I would offer, executive adult protective services, I would offer that this recommendation really fits under safeguards to preventing abuse, neglect, and exploitation.
Okay.
When I think about this, I think when adults have been a victim, they need those services to help talk about the abuse, neglect, to help them overcome what's occurred to them, to help build their resiliency, because we know older adults don't have the amount of time to recover from financial exploitation, things like that. So I don't think it fits where it's at.
I'm seeing head nods on that. Okay, we can move that to abuse, neglect, and exploitation. And we talked about savings already. So action lead, these would be the individual CMHCs. Anyone else? Or is it an agency that needs to be the action lead, and the CMHCs, of course, are the collaborators? Go ahead, Rachel.
I'm going to try this again. And
Oh, better.
oh, good. I'm so glad to hear it. These navigators sound like they are going to be so critical in these services. Who is going to train them? Who is going to see that there's continuity? And how are they going to be educated as to how their own unique individual communities work? Who do we see doing that?
I think that's a great question, and that's who you can decide would be your action lead or a key collaborator to make sure that happens. So thoughts from the group? Is it partnering with universities? Is it agency-driven training?
Executive adult protective services. Ideally, I would like to see them work with the multidisciplinary teams. The legislation that was just approved that the Attorney General's office will be spearheading. So to me, these positions would work, maybe be a part of the multidisciplinary team. But as far as statewide consistency education, I think that's an area that the entire state needs to grow.
Are you, to make this actionable, you have to have someone accountable for it. So who in the state would you want accountable to make sure this happens?
Chrissy, maybe you can help me understand, but when you've got your team of social workers across the state that dive in to investigate these things, how do you all internally handle that training? Is there anything that we might learn about the navigators, about the way that you manage that from your agency?
So, Krista Katib, Adult Protective Services, that is an area where Adult Protective Services definitely needs to strengthen. We're currently working with a VOCA grant to update our manual to provide more consistent training statewide. And I know NAPSA, the National Adult Protective Services Association, within the next year will be having statewide or free APS training. But again, we are doing our absolute best. We're bringing on IDA, which is Interview from Decisional Abilities, which is out of Weill Cornell Medical University. But when we've done our own internal assessment, it's an area where we need to do a better job. And for example, training, we do not have a trainer. It's myself, it's administrators, and then supervisors that are providing that training.
Would you want to have DCF APS take the lead then? Or DCF in general, KDADs?
This is Camille Russell, and I would like to see it be a DCF KDADS collaboration.
Okay. Anyone else that needs to be at the table?
Krista Katib, I would say the Attorney General's office, again, just due to those multidisciplinary teams.
Mm-hmm. Anyone else?
This is Rachel Perner. I'd like to see somebody from KU with the cutting edge work that they're doing there at the med school.
How about Kansas universities?
I like that even better.
Me too.
I know. Well, being in a divided institute where, there's K-State and KU, I try to be inclusive.
Thank you.
Ernie?
Thank you, Ernie Ketzley, ARP Kansas. So I'm wondering, and this is just a question, so if we're talking about education and trainings, if going back up to the Governor's Conference on Aging, if that couldn't be an event where trainings were provided, CUs were offered, sponsorships, those kinds of things. At the Governor's Conference, I know that the addictions and counseling folks in Kansas have a yearly get-together training that they offer CEUs and those kinds of things. So just a question. Pardon my voice. Yep. I'm sorry.
No, you're fine. Can I add that to A3 where it may, and we can definitely add language around the Governor's Conference and others to make sure training and education is a component for every recommendation. Would that be helpful, Ernie? Okay. I want to finish up this one though. Any other thoughts on, could have your association as well? Anyone else? All right.
Rachel Perner again. Who, this is perhaps an ignorant question, but who licenses and certifies the community mental health centers? Is that someone that we ought to either be collaborating with, or is that somebody that needs to be on the action lead?
You have the KDAD's agency as a lead. All right, any other thoughts? Key performance indicators, funding for senior navigators. What else? Take a look at your recommendation. How will you know success? What do you want to see in reports? Number of seniors, provided services in their home. Sorry, I'm hearing an echo again.
Krista Khatib, yes, I would like to see the number of seniors served. I would also like to see a reduction in hospitalizations.
Mm-hmm.
And I'd like to see a reduction in abuse, neglect, and exploitation.
And would you do that through less reporting of A&E? Is there a report that tells you number of?
Yes, I think we would have to tease that out, but there is a way that we could track that.
Okay, just making sure it's feasible to track it.
This is Camille, long-term care ombudsman, and I actually have a question for Chrissy. Do you believe that this also would go to a reduction in self-neglect?
Yes, thank you. I would very much hope so, Camille.
Okay.
Rachel Perner, I'd
Mhm.
also like to see locations, not just the number of seniors served, but where are we serving them?
By how about service location? Should we do that? Would that work?
Yes.
Example, in-home versus facility. How's that?
Actually, I'm thinking learners
geographic.
versus Kansas
Yeah.
City geographically.
Geographically, rural, urban, frontier. Okay. Okay. All right. Move us along then. Your next one is to improve upon existing standard training and education by requiring CE requirements for surveyors, direct care workers, providers, prescribers, and family members on the interaction of prescribed psychotropic medications to treat dementia, depression management, geriatric behavioral health, and so forth. Facilities that implemented training will be referred to dementia certificate programs and resources for long-term care providers and prescribers. Edits to the language first, please. And this is a subset of this. Go ahead, Jan.
Do we need to also add that says long-term care providers, but we're talking about in-home as well, is that right on this? So
Do you want that in the list of long-term
Well-
care providers?
my concern is that sometimes the phrase long-term care providers might be exactly talking about someone in the home is their long-term care provider. You know, I mean, that's cutting, but it's not just in a facility, but also at home to be able to have some, but I get it that it's, they wouldn't get a certificate, but they need the training. I don't.
Do you want to add something specific for in-home?
That might help, yeah. Let's see. In-home training will be offered to caregivers in dementia care recognition. Somebody help.
Hi, this is Lee Chaffee from Brewster.
Mm-hmm.
Can you all hear me?
Yes.
Yeah.
Okay, my thoughts on this, kind of, I guess, requirements, continuing education requirements. The scope of this looks really big. Direct care workers, you're going to have to go through a lot of different agencies and possibly legislation to change continuing education requirements. I believe that the state does govern long-term care administrators, CNAs, the Kansas Board of Nursing. That could be doable, but providers and prescribers Is it the state that mandates their continuing education requirements? I just think this is a huge scope. And correct me if I'm wrong, anybody who might know more about this than me. I do believe that the training should be offered, but I'm just trying to figure out the direction we take as far as the requirement. That's where I'm trying to figure out, how are you requiring this and through what method? Family members, how are you requiring that? Is it through a state regulation? I guess those are my questions on this specific one, and I think Jan's correct. For out in the community, how do you make sure they get the appropriate education? Because that's really our intent here, is to make sure people are educated on this. That's my thoughts.
I saw Camille's hand go up.
Well, and I'm readjusting my computer here so I'm not crooked. So how this is worded is we are, and I'm not really addressing what was just said. I'm back to before that. So the wording is including violence de-escalation. So if we've gotten to the point where there's violence, we have already missed the mark on our training. Not that it will never occur, but our training should be addressing the effective intervention and reduction of behavioral and psychiatric symptoms of dementia. And so our training should help the providers, the family members, everyone address that person with dementia in a way that we would reduce the fact that there would even be any symptoms. I really would like for us not to have violence in there. When a person who has dementia is communicating through behavior, it is not their intention to be violent. And I feel like we're labeling their communication.
Everyone comfortable with adding effective intervention and removing violence de-escalation? Any objections? Okay. So then it would be including effective intervention and appropriate use and use of, right?
Yeah.
And non-pharmacological approaches. Okay. I'll work on the English. So to go back to Lee's question, there are two mechanisms you can think of. One, you could turn the requiring of the continuing education requirement, CE requirement, to an action step. And then whoever the lead is can decide whether that requirement is feasible or not to execute it, versus keeping it in the body of the recommendation if you choose to, or you keep it in there and then charge someone who is the lead to figure it out. Go ahead, Ernie.
Yes, Ernie Cutzley, ARP Kansas. So in our reaching out to folks for education, for in-home trainings and outreach, do we include anywhere VA hospitals looking at those veterans that may have access or may not know they have access to care?
That's not part of the recommendation. So
Just
I'm hearing it from an access to care versus training of caregiver.
Well, both, actually.
So is this the promotion of the service itself?
Yeah, so if someone has, and they're a caregiver, and someone has a member of their family, loved one, whatever, that may exhibit or start exhibiting symptoms of dementia or need some sort of prescribed psychotropic medications, if they look at the person as a veteran, to reach out to those veterans hospitals in the state. Not
Okay.
sure, I'm just asking, yeah. Thank you.
I know Working Group B has a marketing promoting recommendation. However, you can add it as an action step here. So that's up to the working group. I saw Rachel's hand go up, I think.
Yeah, Rachel Perner. Did the navigators have any role in this and facilitating and referring the training and education?
You could. Let's go back up. You've asked the navigate. Oh, sorry, I went too high. You've asked the navigator to be at each CMHC who will assist or refer with navigating mental health services for family and caregivers. And so we could include veterans here as a population if that suffices, Ernie, or add it to the recommendation below,
Or both.
or both.
Already Ketzley with AARP Kansas. That would be good. I was also thinking about the VA hospitals and care provided there as outreach and education for abuse and neglect.
We're still on
Also,
antipsychotics. We'll get
I
to
know.
abuse and neglect in a sec.
Thank you.
But yes, do you want it in both places?
Yes, please. Thank you.
So what language would you like? Particularly to those for veteran services? How would you like to identify that?
I'm sorry, where are you now with your cursor?
Oh, sorry.
It's all right.
I'm
Oops, way
seeing
up
one.
there.
Yeah. So here we are.
And you said veteran services?
Yeah, such as oh, I apologize, everyone. My screen is frozen.
Sorry, I didn't mean to break it.
No, that's not your fault. There, that worked better. Such as for veteran services.
That's fine for now.
For now, let's keep that as a placeholder and come back to that. Okay.
Thank you.
And then you wanted it again down here, right? So ensure effective marketing, or is it marketing that you want, or if to populations such as veterans?
I think marketing or education services, education outreach services to
Mm-hmm.
Kansas veterans populations and caregivers.
Mm-hmm. Okay. Any objections or edits? Any edits or objections to this? All right. So what type of program is this? Is this something new? And then before we go on to that, do you want to keep continuing education in the recommendation or pull it down as an action step?
I have a question about the words by requiring. If you were to remove by requiring, does that weaken this? Because we start out improve upon existing training and education
Mm-hmm.
for
When
surveyors.
when this was proposed, the person proposing it had discussed making it a stronger recommendation by requiring CEs,
Okay.
because otherwise anyone training and education was available. But if CEs are
If it's
required,
required. Okay.
and I will say the working group B has a similar recommendation where they are requiring 4 hours initial and 2 hours. They actually have specific language. So I may just share that with you, but they are saying 4 hours of initial training and 2 hours annual training for actually dementia, geriatric behavioral health, and then general healthcare professionals as well. So they do have specificity in their recommendations too, if that's helpful.
Okay.
So would you like to keep it up here then, or would you like to bring it out like this? And you would remove this if you kept step D.
No, I don't. But I think I guess we probably have to leave by requiring, otherwise it won't get done. So, because,
Okay. All right. Then
thank you.
that's what we're doing.
Yeah, thank you.
Okay. So then is this a change, an overhaul, something new? There are existing CE requirements from what Working Group B has said. So I would suggest a change.
This is Camille, and I would say that it is a change, though it may feel like an overhaul because it feels like it's not getting done, but it is a change.
Okay. Any cost issues? Strategies for continuity. If it's CEs, then you have that built in, right? All right, then you have, some of it's part of the regulatory process. As Lee had pointed out before, it's a lot of regulatory boards that you need to think about when you have continuing education credits, and then establishing some way that family members would have the certification as well. Any other processes besides regulatory?
Technology?
Yeah, we can keep technology. Lee, are you comfortable with keeping it as is with the CE in there? I didn't come back to you. I apologize.
Yes, this is Lee Chaffee. I'm comfortable with that. I just think it's a large scope. But like you said, we can direct it to someone and they can figure out how to make that happen.
Okay. What are some subpopulations that will really benefit from this?
All of
Are there
those.
any? All of them? Any, I guess any that don't benefit.
Sort of those.
Any in particular, really?
Those under 60. Because we're still talking about senior population.
Yep. Okay. Is there cost savings that can be produced in other areas based on this?
Yeah.
How so? Expand on that,
Keeping
please.
them healthy.
In home, in the community? Okay. Who do you want as the lead?
This is Rachel Perner. It still seems like there ought to be a place for the navigators working with the individuals, the individual caregivers. That feels like it's missing. When you're dealing with institutions, you've got these other folks.
So the navigators are housed at the community mental health centers. Would you like them housed somewhere else? Is that what you're suggesting?
No, not at all. But I think that part of their checklist needs to be, when they're evaluating and helping for services, that they're likewise ushering people over the training that they need when they're individual caregivers.
You going to pull this out as a separate recommendation and have a lot of context around it? We do have and provide education as language we are going to add to this recommendation, but I feel like maybe it feels too nested. Go ahead, Chrissy.
Krista Katiba, Adult Protective Services. I think what Rachel is indicating not only would be for the involved adult, but for their informal support, formal or informal supports, their caregiver supports.
Rachel, again, that's better put, Chrissy, and the education and resources for them to be able to provide that care to their loved ones.
And I would just like to say I absolutely concur.
Does that work? Veterans doesn't work now. Is that the intent, Rachel?
Yes, ma'am.
Okay. Any other edits? All right. So going back to that one where you want CEs for lots of education, who do you want to lead that? You're definitely going to have all your regulatory agencies, regulatory bodies, but who else? Who do you want to lead this? Is this a KDADS thing, a DCF thing, an agency thing? Is it?
This is Lee Chaffee.
Mhm.
I believe that KDADS probably has the biggest umbrella for this, so they
Mhm.
would be one. I'm not sure who because they do. Is the BSRB under KDADS? Do you know?
It's a regulatory body.
So they would do any social workers. I believe they do mental health professionals.
They do.
Okay.
Do you
I'm
want
not
them as a
sure.
lead then, maybe?
No, well, they might need to be. And then I don't know who does actual prescribers. Who regulates? Does the Kansas Board of Nursing do continuing ed for like nurse practitioners? And then who does the continuing education requirements for physicians?
BOHUB
Those would
does
all
it. The Board of Healing Arts does physicians, and then Board of Nursing for your nurses, and BSRB for your the other social workers and licensed mental health technicians and all of those. Actually, licensed mental health technicians may be under Board of Nursing, but we can put all of the regulatory bodies so you have them.
I think that would be good. Thank you.
Okay. I think someone was speaking. All right. What do you want to see? What are some performance indicators? Is it similar to
Lee. Well, this is Lee Chaffee, and I'm not sure, I mean, this isn't addressed anywhere. So the adult care homes have data and metrics for their use of antipsychotic medication. So that's been a hot topic. It's out there, the percentage of use for Kansas, and then for each individual home. The thing that is not studied or that we do not have good data on is the use of antipsychotics for those in the community. So it would be hard to have a performance indicator because we don't really have a baseline performance indicator of what's going on with folks in the community. You would almost need to establish that through the community health centers or something. But for adult care homes, you have a great data point already that you could point to perhaps, and then maybe Camille could chime in on this one with her thoughts.
Go ahead, Camille.
This is Camille, State Long-Term Care Ombudsman. So it would only be for Medicaid recipients, but the MCOs would be able to, if they were asked to track anywhere the location of the individual. So it could be tracked at least that way for a performance indicator in the community.
Okay. I added them in as key collaborators if you want them tracking things. Any others?
Jan Kimbrell, is there any way to track emergency room visits? Because would want, I don't know exactly, it's just coming to my mind that at home, when somebody is having a crisis, they are often taken to the emergency room and, you know, the history is taken and.
Yeah, KDHE has a pretty robust ER database, so you could get that from there.
Is that is that hidden by privacy, or would this? Gosh, what happened to my voice? Would that data be available? Would that be helpful?
As long as you ask for aggregate data, I would assume that. But are you seeing reduction in number of ER visits related to antipsychotic use?
Yeah, that's what I was thinking.
We would have to, I can reach out to them and ask if that level, what their reporting systems are, if that's helpful. What data they do report.
Yeah, because it might just be, you know, an adjustment in medication is all that's needed.
Sure.
Or or an increase in the, and sometimes the ER, you know, these things don't happen during office hours usually.
Mhm.
And
And I think we had a different word for this, and so I'll make sure that's consistent as well. Any other hands go up? I think I saw Camille's hand. And then Tracy. Oh, Camille, you're on
The
mute.
word you're looking for that we used before.
Did it
was psych-
backwards. Sorry. This is Camille. I was on mute. I'm sorry. So the measurement also, in addition to actual hospitals for the reasons that Jan indicated, would be a measurement of individuals who are referred to possibly Jerry Sykes for medication
Yeah.
purposes. And so the reduction of antipsychotics is, I think, what we're going for with this training. And typically what happens when people are referred to the Jerry Sykes is they are given the antipsychotics.
Do you want me to ask about referrals too?
So I think there'd be separate measurements between acute care
Yeah.
hospitals and, yeah.
So do you want reduction in number of referrals or just understanding the number of referrals?
Yes, it would be a behavioral event that would allow typically supposed to allow for that transfer to a Jerry Psych unit. And it would, so you would have a reduction in those if the behavioral intervention, the trainings that we were providing to, we should see a reduction in those.
Okay. Any others? I saw a lot of hands go up and I didn't pay attention, but I think I saw Tracy and Rachel and then Jen.
thank you.
Tracy?
Oh, I was just going to tell you that the word that you were looking for instead of antipsychotic was psychotropic.
Oh, thank you. I appreciate that. And then Rachel?
Now, tying into the geriatric psychiatric units, a lot of times these individuals will end up in care and treatment proceedings on the legal side.
Okay.
And so there might be a measuring stick there.
Is that correct?
Yes.
And would that be through
Those
the courts that you would get the data? How would you get that data?
Well, I would think that the raw data would be available from
Like at
the
OJA?
Supreme Court, right?
Okay.
You know, the identity of the individuals is protected, but the referrals to the psychiatric units are not all going to result in a court finding an individual is a danger to self or others. But
Sure. We could reach out to OJA to see what data is collected in their Odyssey unit. Okay. Any others? Jan, you had a comment, I think, and Ernie, and then I'm going to move us on after.
Yes, my concern is the current amount of geriatric psychiatric units. I know they have been substantially reduced across the state, and hospitals that used to have specific geriatric psych attached to their hospitals no longer have them. So that is my concern that.
So availability or increased number as well?
Well, to recognize yeah.
So how about just number of? So you have
Yeah.
psychiatric beds, is that what I'm hearing?
Because there aren't geriatric psych units everywhere is why there's increased ER visits, because they don't know what to do, so they take them.
Okay.
This is Dr. Tracy Davies, nurse practitioner. I just want to mention just a comment on that. One of the reasons for that is because they changed the reimbursement of what the purpose of the hospital admission was, and that it couldn't be for dementia-related symptoms, and that's why that happened.
Yeah, it's a problem.
I think that was very unfortunate.
That's a federal change? Okay. So this will give you baseline data, but it's not a KPI. Okay.
Right.
Thank you for that context, though. Did I miss any hands? Ernie, did we get to you?
No, I had a quick question. Thank you, Ernie Kinsley, ARP Kansas. It was a follow-up to, I believe, Lee's first comment on the community established baseline for antipsychotics, and we're
Yeah.
talking about reductions. Are we also talking about reductions in the use of antipsychotics in nursing homes and long-term care settings?
In community, nursing homes, and long-term care settings. How about we get them all? Sound good?
Sounds good. Thank you.
Okay. Thank you for that clarity. Any others?
This is Camille, and I think Ernie did say it, but it does include antipsychotics.
Tracy, I'm going to refer to you. Is psychotropic medications the umbrella that includes antipsychotics, or do you have to write them separately?
No, it includes antipsychotics. Our previous discussion was that there is sort of a reaction then, when you start limiting clinician decision making on treating patients, that, okay, well, we can't do this, so we're going to do something else, and it's in the same vein. Then we create a problem there. We use different psychotropics to try to achieve what we would have tried to achieve to control symptoms that would be better managed by antipsychotics, with judicious clinical review. So I think it's important to keep it psychotropic so that we can make sure that we don't kick the can down the road, I guess. And then we're talking about different medication,
And then the group itself, I know that these topics are assigned through legislation, but you could rename your group as use of psychotropic medications. There's nothing that precludes you from doing that. So that's something you can decide. All right. Anything else on this recommendation? Otherwise, I'm going to move us on. All right. Your last one for this section. Provide an updated list of Kansas physicians, mental health professionals, and telehealth providers into an informational packet to be distributed across the state with additional instruction for accessing services for care, homes, and residents. So this is your education outreach recommendation. I didn't know if we wanted to send this to working group B or workforce because they have similar things, but also each working group saying the same thing is okay too. So I leave that to you as working group members. I see Jan's hand up. Any edits to this language?
Well, are we going to include caregivers, family caregivers for that updated list? Or
Sure.
is this only going to care homes and residents in care homes?
I think the intention of the residents was in home. So consistency of language is terrific. So let's say caregivers, in-home residents. Does that work? I'm gonna have to think about this language. I'll look at a few reports to see what the best terms are. But I get your intention. I've captured that.
Thank you. Yeah.
And then just know that there is a task force recommendation about mapping geriatric services available across the state that one of the working groups also has.
Yeah.
And so this would be an informational packet so that there's something that's tangible and printed along with electronic. Any other clarity in the language? All right. What type of initiative is this? Just a quick change, something new, but not too different? Okay.
I think it's a change.
A change. Okay. And then cost to be a barrier.
Sure.
You could go to your boards and get your list of, it would be just working with these universities with mapping. So you can have your caregivers listed in your communities. Strategies for continuity. How often would you want this updated? An informational packet. Is this something annual, every 2 to 3 years?
2 to 3.
How are you going to achieve this? Through a contract with somebody?
Well, this is Lee Chaffee.
Go ahead, Lee.
I know that the AAAs, they always put out a resource book. How is that annually?
Yeah,
Could
Could
go
that,
up
booklet
could that
came
be
up
done?
actually in Working Group B, Lee, so I'm glad you brought it up. That booklet
Yeah,
is one of their recommendations actually because it's gone now. So they actually have a recommendation to bring the booklet back.
yeah, the booklet's helpful, and if we could achieve this through that booklet, it was, I mean, as
Yeah.
a social worker, when I was doing that, that book was my Bible, and then the Bible I used for, you know, people I was
Sure.
trying to help, because it was just such a valuable tool of resources.
You brought up AAAs, and we haven't mentioned them as key collaborators anywhere. Would you want to think about them as collaborators in some of these things, not just the CMHCs, but also the AAAs?
Well, I think specifically for resource collaborator, I mean, for this specifically, yes, the AAAs should be in this.
Go ahead, Camille. Camille?
It seems like the other work group is on track with this, and that
Mhm.
I would vote that we concur with that, the way that they're progressing. And yes, the AAAs, yeah, whatever we need to do, support that.
Okay. How about I recognize that in the rationale of this recommendation, and we can link the two recommendations together. Does that work? All right. You've got AAAs in here with this education resource. You definitely have universities and others. Who would, I think I saw, is it KDAD's Legislature? Who's the funding source? I know the Senior Care Act
AAAs.
provides funding as well for AAAs.
It would be KDAD's.
Okay. All right. Anything else? How about indicators? What do you want to see? How do you know that there's success?
This is Lee Chaffee from Brewster Place. This is a tough one because I believe that the reason we put this on here was because we all know there's a severe lack of resources, but again, I don't know that there's a baseline performance indicator other than,
Yeah.
you know, providers and consumers reporting that they don't know what the resources are. So I
Right.
would say that the seniors, you know, reporting that they have a good understanding of resources in the community, but I don't know, it's hard to have a performance indicator when you don't have a baseline performance indicator.
Your workforce group does have a research study they're recommending and talking to seniors to see what services and resources are available. And so they've got you kind of covered there, if that helps to give you a baseline.
That does help. That does help.
Dan Kimbrell, silver-haired legislator, I know that senior centers through AAA have an annual survey that they ask seniors in the communities to respond to about services in their community. And they're about to have one. Again, this is coming up right now. So through the AAA, that information should be available because they do it annually.
Okay.
Chrissy Katib, Adult Protective Services. I just keep thinking about if this is well-marketed, centralized, web-based, quite simply, you could just also look at the number of clicks. So the first year, if you have so many views, and the next year, the percentage of increase in views.
I know this one doesn't get to those that don't have broadband internet or don't have the ability to use the computer or know how to use the computer. However, we'll add it to the list as one of the indicators. Just acknowledging that as you guys have discussed that heavily. All right, that's a good list. That's one topic, guys. We haven't gotten into abuse, neglect, and exploitation, but guess what? Whatever we don't get done, you guys get to fill out the survey on your own. And I mean, the point of this is so you guys kind of see the process. And so when you're filling out that survey, you know what we're looking for. And so the next time we can just compile all of that for you, and then you're just ranking these. Okay, so we're going to start on our next topic, safeguards to prevent abuse, neglect, and exploitation. Your first one is to enhance safeguards and oversight of guardians, conservators, and paid family caregivers by establishing navigator coordinator position or a database to access between your agencies, DCF, KDADS, KBI, that the facilities can contact or the family when questions about appropriate hires may be in question. The one recommendation that we thought was kind of similar, but we weren't sure if you wanted to keep separate, is to integrate the direct care registries to create a clearinghouse of data for the consumers and courts, increase accessibility and review, and provide avenues for information sharing with the public. So my first question to you all will be, do E1 and E9 align, relate at all? And if they want to keep them separate, please keep them separate. I just wasn't sure if they were getting at the same thing. Go ahead, Rachel.
Rachel Perner, to my way of thinking, they're both trying to achieve the same objective, which is to get a clearinghouse.
Would you want to say that up here, establish a clearinghouse and then write the rest of the recommendation?
Yes, I think I would. You know, the idea being that we create
Kind of like
something.
that?
Yeah. Some unified place to go check all of these different records.
Do you want to remove the navigator position then, or keep it as a steward?
I like having a person, you know, an entity. Whether we call them a navigator, that might be kind of confusing with the other navigator we've been talking to.
This is Camille. I think people understand coordinator as a
Don't mind my line editing. I promise this will go through communications and line editing. Okay, how's that sound?
It's Rachel. I like it.
Okay. How do you want to integrate E9 into it? Or do you want to remove E9 now and that's part of your kind of rationale?
This is Camille. If we added the words direct care worker to E1, would that get rid of E9?
Rachel here, I think we need to add increase accessibility to E1, and with Camille's friendly amendment, I think E9 can go away.
Okay. So I'm looking at where to put this. That the facilities can contact to increase accessibility and enhance. How about that? Okay, and then paid caregivers. How about which includes or including direct work?
Would it also be Jan Kimbrell, silver hair, unpaid family caregivers in that as well, or is that overreaching? I mean, you know, there are some unpaid family caregivers causing harm. Money's not always the issue.
Do you want to remove the word paid?
Well, it does it for me, but what about everybody else?
Any objections to that? I see some thumbs ups. Okay. How's that language look? All right.
This is Rachel. Why do we want to limit it to family caregivers?
Do you want to just say caregivers?
Yes, because in the private context, it might be family, it might be, any number of
Be
other,
the neighbor, yeah.
right, unpedigreed individuals.
Mm-hmm. How about we just say that facilities and individuals can refer to? How's that language? Seeing good thumbs ups. Thank you. Okay. So this is something new, right? Does it exist? Is it something that you are changing, or is this from scratch?
Isn't it a change because it's updating what's currently out there?
Is there
Just-
something currently out there? Is there a clearinghouse of some sort?
It's not up to date if there is. That explore your options was not up to date, and other information that AAA's put out is not up to date.
Okay.
So
Everyone agree it's a change then?
I don't really know. This is Rachel. I don't really know how to define a change. I mean, it sounds like each of these entities silos information. And so if we're consolidating their data or creating something
okay.
that houses all of the data under one roof, I don't know whether that's new or whether that's a change.
Could be an overhaul as well.
Yeah. Yeah. Or replacing. Yeah. Overhaul.
How about an overhaul? Because you're taking all of their systems that do exist, but repackaging them. And this is just kind of language to help you think about how difficult it could be to implement a recommendation. So cost be a barrier to this?
Jan Kimbrell, it could be cost savings because you might find duplication of services that
Okay.
might streamline it, perhaps.
Yep. Okay. I see what you're saying. How often would you want it updated? Should it be continuously updated, annual reviews, 2 to 3 years?
I think it's Rachel. I think it ought to be a continuous update.
Okay. Any objections? And how are you going to achieve this? How will the state achieve this? Is this through kind of contracts, agency budget, legislative action for funds? What do you think?
Technology infrastructure for sure, but there
Mhm.
are others.
Is there any legislative process needed in here? Go ahead, Chrissy.
So I just want to reiterate that some of this would require legislative changes
Mhm.
because databases aren't open to the public. Like for example, adult protective services, if somebody is substantiated for abuse, neglect, or exploitation, their name would be placed on the central registry. To review the registry, you would need to get a release of information from that individual to check our registry. So
Okay.
just wanting to make sure the group knows that.
So you definitely need legislative session. You would need some agency budget development to be able to put the registry together and some technology infrastructure. Thank you for that point, Chrissy. Does it significantly impact any of these subpopulations? Anyone in particular? Or is it more general for the overall senior population? Okay.
I think it does it all.
Okay. We talked about cost savings. Since it's a collaboration, I just put the 3 agencies that were identified in the recommendation there. You need legislation. You need the legislature, right? Who else?
This is Camille. I would put the Attorney General's office on that key collaborator.
Sure.
This is Rachel, and I would add OJA on the collaborators.
Okay. Any regulatory bodies needed?
This is Camille. Once the legislative piece is done, absolutely, the regulatory folks will have to do their thing.
Okay. If you think of any others, let me know. Otherwise, what are some indicators?
This is Chrissy. You could measure just the number of checks on this centralized registry.
Okay.
It's Rachel. Chrissy, I've got a question for you. Would you expect with this type of clearance going on and accessibility, would you expect to see a lower number in open investigations in adult protective services?
So Rachel, I don't know if I'm understanding the question. So are you saying if this sort of open registry was available, would I anticipate a decrease in investigations at our agency?
Yes, if we were able to prevent the exploiters from having access to grandma, for example, do you think that that would impact
Gotcha.
the number?
So I personally have mixed feelings on that because what we do know nationally is that elder abuse is underreported. And so ideally what we want is more people to come forward. So that could inversely,
Could increase the
does that make sense? If we get more people to come forward, those numbers, we still may have the same amount of investigations, but it wouldn't be negative, if that makes sense. We want more people to come forward.
Am I hearing that you wouldn't want that as a performance indicator then?
Right.
Okay. Everyone agree with that?
Correct.
All right, Camille?
I would say that a performance indicator might be that we not have repeat offenders. So, a person who would be substantiated a second time, because we wouldn't be hiring them or utilizing their services. I mean, that would be a performance measure that I would hope for.
And then Rachel, I felt like you were trying to say something, maybe another indicator.
It might be that we could look at a reduction of criminal prosecutions for exploitation of this population.
This is Camille again, and I almost would have to say, though, I wish we would see, and I think we're going to have to see an increase in criminal prosecutions before we see a reduction in exploitation. So I'd ask for us to think about that too.
How about trends?
Jan Kimbrell, silver-haired. I was going to ask if we wouldn't want to have the reduction in the need for prosecution because it's going to stop or slow way down by this being available. Because we want less criminal actions against seniors.
So this is Christy, and I'm not sure how we would track it, but ideally what I think we want is that if somebody is on a registry, we don't want them providing direct care services to our vulnerable adults.
Right.
So I'm just trying to figure out how we would word
Yeah, so you have
that
repeat
they're not
offenders in here,
in.
but ensure substantiated. Direct care workers. No longer seek employment.
Those substantiated for abuse, neglect, or exploitation are not employed in direct care services.
Okay. I know we
But
captured
again,
that
I'm
in our
not
notes.
quite sure how
so,
we
yeah.
track that.
Okay. We'll look into that one. All right. So we are at time. You will get a survey probably tomorrow, Wednesday or Thursday at the latest. I mean, Thursday or Friday at the latest. You are welcome, those of you on this working group meeting, to skip over those initial recommendations we've already done together, or you can contribute to the survey. I leave that to you. We do ask your name on the survey solely in case we have any clarifying questions. The data will be aggregated and compiled so that when you see the survey results, the next thing we're going to do is start ranking and scoring these recommendations against each other to see what's actually achievable and not, to help you tier them and really look at those downstream effects. If you had this clearinghouse or if you had this education and outreach in your first tier, then what could you put into your second tier? Because there's some good downstream or cost saving effects. Or vice versa, put that in your second and put something else in your first tier. So think about it from that perspective. So your next meeting is on May 24th. If everyone completes the survey, then we can have a very meaningful conversation then in tiering these. If they do not, then we will be doing a lot of this exercise then. The survey will also be give you space to add any changes to the language as well, and that can be vetted at the next meeting as well. So don't think that you can't continue refining language. I think we've refined language even like as we're ratifying the report too. So don't think that that space isn't there for you. There's always language that can be better developed. If there is nothing else, I thank you for your time today and wish you the best this week.
Thank you.
Thank you. Bye.
Thanks, everyone.